You're welcome. Today we are going to talk about peptic ulcer disease, also abbreviated as PUD. Please don't forget to subscribe and like the video. Peptic ulcer disease can also be defined as the break in the inner lining of the stomach or the duodenum. Can also be defined as the ulceration in the inner lining of the stomach or the duodenum. So when we talk about the inner lining, we mean the mucosa. So the cause of ulcers is due to the imbalance of the digestive activity, the pepsin enzyme, and the protective mechanisms in place to resist the mucosal digestion. If there is an imbalance within those three, then stomach acids will be able to damage the digestive tract. According to the digestive organ which is affected, we can give them terms. If it is the stomach which is affected, they will be called gastric ulcers. If it is the duodenum which is affected, we shall call them duodenal ulcers. If it is the esophagus which is affected, we shall call them esophageal ulcers. We go to the causes of PUD. PUD, remember we said it means peptic ulcer disease. The first cause is a gram-negative bacteria, Helicobacter pylori. This bacteria, it goes in and invades the mucosa of the digestive system. Then two anti-inflammatory drugs like aspirin, diclofenac, and others. We have discussed, there is a presentation. When you go in those videos, you'll see we talked about diclofenac, and you'll get to know how it causes PUD or how it causes ulcers. And the core reason why anti-inflammatory drugs cause PUD is because they block COX-1 and COX-2. 3. Stress also causes PUD. Smoking. There is evidence that people who smoke, they have a risk of increased production of hydrochloric acid, and there will be reduced production of bicarbonates. Alcoholism. Too much alcohol irritates the stomach lining. Then how does diet cause PUD? That is through irregular meals. Then taking foods or the diet containing caffeine, like beverages containing caffeine, spicy foods, and acidic foods. Signs and symptoms. The first symptom is epigastric pain, but we can get to know which area of the digestive system is affected according to how the pain is. Like if the pain is worse at night and when hungry, most likely they are duodenal ulcers, and these are alleviated by food, milk, or an antacid medication. Then the pain which is worse with food, after eating you get that epigastric pain, most likely they are gastric ulcers. Another clinical manifestation is nausea and vomiting. And if the patient is vomiting coffee brown or red vomitus, then it means it is hematemesis. That is vomiting of blood. So that is a mixture of blood and food. Then the other one is regurgitation. Regurgitation, this is the rising of a mixture of gastric juices and sometimes undigested food through the esophagus, then into the mouth. Then we have melena, black stools, and why this stool will be black, it is the mixture of blood with stool. Then, and the presence of blood in stool is called melena. We have a cold clammy skin when the patient has lost a lot of blood. The cold clammy skin is due to the anemia, then the dehydration, because this patient is losing blood, so these signs will come up, the cold clammy skin. The fevers are due to the inflammatory process. Loss of appetite. Remember, in gastric ulcers, as long as you put food, then you get the pain, meaning you'll be discouraged to eat. Then bloating or abdominal fullness, and bloating is the buildup of gas in the stomach. So those are some of the signs and symptoms. Investigation. So which investigations can we do to confirm that this patient has peptic ulcer disease? The first investigation is stool antigen test. Stool antigen test, the lab attendant will pick a stool sample from the patient, and this sample or this test may give false results in patients who have been taking antibiotics or omeprazole in the previous 2 weeks. So patients who have been taking antibiotics and omeprazole in the past 2 weeks, we may get a negative test, yet the patient is positive. Still, stool antigen test is used for confirmation and eradication. So if we want to confirm this patient has PUD, it is the confirmatory test. Then if for eradication we shall do it at least after 2 weeks of taking the medication, or after 2 months. Then the other one is the serum antibody test. The lab technician will come and pick a blood sample. We can also do a gastroscopy. This often takes less time, like 15 minutes, and in this procedure, a thin flexible tube called the endoscope is used to look inside the gullet. Gullet means the esophagus, the stomach, and the duodenum. And at the end, it has a light and camera. So they will use that thin flexible tube which has a camera and light at the end to examine the GIT. Then a biopsy of the stomach wall can be also taken. So here a small tissue is taken for examination. We can also do a barium meal. A barium meal can also be called an upper gastrointestinal series. Here a series of radiographs is used to examine the GIT for any abnormalities. So after doing the investigations, we can talk about the differential diagnosis, and this is the process of differentiating between 2 or more conditions in which they share similar signs and symptoms. The first differential diagnosis can be pancreatitis, which is the inflammation of the pancreas. Then hepatitis, which is inflammation of the liver. Lung diseases or hemoptysis. Hemoptysis means coughing up of blood. Then myocardial infarction. This is failure to supply, when there is some limited supply of blood to a heart muscle. Gastroenteritis, inflammation of the mucosa of the GIT. We can talk of also the gastroesophageal reflux disease. This is a disease in which the stomach acid or the bile irritates the food pipe lining. then stomach cancer, and last differential diagnosis is cholecystitis, which is the inflammation of the gallbladder. Then we can go to the pharmacological treatment. How do we treat peptic ulcers, or how do we treat peptic ulcer disease? A triple therapy for H. pylori infection remains an option for the first line therapy. We are going to see the first line treatment, but let's first see the drug classes which have been at least put in the eradication of H. pylori. The first one is the proton pump inhibitor. The main action is through a profound and prolonged reduction of stomach production. In the reduction of stomach acid production. And stomach acid production, it means hydrochloric acid production. So the proton pump inhibitors, they work by reducing stomach acid production. And examples, we have omeprazole, which is given 20 milligrams twice a day for 2 weeks, or it can be increased to 40 milligrams in severe cases. Then we have lansoprazole. In adults, we give 15 milligrams once a day, and in severe cases we can give 30 milligrams OD for up to 2 weeks. Then we have another drug which is esomeprazole. Then esomeprazole, it has 3 types. We have esomeprazole sodium, which is in IV form. Then we have strontium, which is a delayed release capsule. Then esomeprazole magnesium, which is the oral form. This we give 20 milligrams to 40 milligrams orally, or D for 2 weeks. But we are talking about this duration 2 weeks, but your health attendant, your doctor or your physician can increase the dose accordingly or reduce. Then we have pantoprazole, which is given 40 milligrams orally once a day for 2 weeks. We have another class which is H2 receptor antagonists, also known as H2 blockers. These block the action of histamine at the H2 receptors of the parental cells in the stomach. Parental cells. So parental cells are epithelial cells that secrete hydrochloric acid. So meaning, let's first understand the role of histamine. Histamine is involved in the inflammatory response, and most times it is found in mast cells and basophils. If histamine is blocked to reach the parental cells to receive them, meaning the parental cells will not produce acids. So the acid we are talking about is the hydrochloric acid, meaning the process of producing hydrochloric acid will be cut off. In that process, there will be stability in the pH within the stomach. So examples, we have cimetidine, which is taken 400 milligrams twice a day with food, meaning at breakfast, with breakfast or with food, and at bed time. Ranitidine is given 50 milligrams every 6 to 8 hours. So here we are talking IV. 50 milligrams every 6 to 8 hours diluted to a total volume of 20 mils of dextrose or 0.9 normal saline. Meaning if it is 2 mils, you will top up with 18 mils. But if we are giving it IM or intramuscularly, we don't dilute. We also have tablets of ranitidine, where we give 150 milligrams. We talk about the last H2 receptor antagonist, which is nizatidine. Adult dose 150 milligrams orally twice a day up to 2 weeks. Then the other class of drugs we give are the macrolides. And in the macrolides we have many drugs, but I picked those which are commonly used in the treatment of PUD. There are other macrolides which are used in treating other conditions, but I picked the drugs which are mostly used in the treatment of PUD. And the most used one is clarithromycin, where we give 250 milligrams orally twice a day for 2 weeks. Then azithromycin sometimes is also used. The other class is the penicillins. How do the penicillins work? These work by inhibiting cell wall synthesis. The most commonly used penicillin is amoxicillin, where I give an adult dose of 1 gram orally twice a day for 2 weeks. The other class which is used is the nitromidazole. And here we have 2 drugs which are commonly used. That is metronidazole, where I give 400 milligrams orally twice a day for 2 weeks, and tinidazole 500 milligrams orally twice a day for 2 weeks. So those are the drug classes which are used. Then we have the first line treatment. In the first line treatment, mostly we give amoxicillin, which is a penicillin, plus metronidazole, plus a protein pump inhibitor. And in the protein pump inhibitors we talked about omeprazole, and others. But the mostly used ones, it is a combination of amoxicillin, metronidazole, and omeprazole. Another line which is used is clarithromycin, lansoprazole, and tinidazole. So that is the triple therapy we talked about, where we have 3 classes of drugs that have been used. But in some people we have also found out that some people use antacids to reduce the signs and symptoms. In case the triple therapy is not around, you can give antacids to reduce on the signs and symptoms. And the antacids we can talk about magnesium trisilicate and many others. And in magnesium trisilicate we give 2 tabs 80 hourly. Then let's talk about the complications. So this is when we have delayed to treat, or if we don't treat, what happens? And all these will come because the acids, they eat up the mucosa, or they eat up the inner lining of the stomach or the duodenum. After eating up, it means they are creating wounds. As those wounds widen, they are creating holes. So that's where we shall start to see the complications. And the first complication is the perforation. It's what I've been explaining. The perforation comes as the wounds widen they are creating a hole. So after creating that hole, remember, it's a wound where they are eating. There will be internal bleeding. After the internal bleeding, as the patient loses much of the blood, there will be anemia. And that when there is internal bleeding, that blood is going, or it is contaminating the peritoneal cavity, and there will be peritonitis. Then the last complication is pyloric stenosis. Sorry about the pronunciation. And this is the narrowing of the opening between the stomach and the duodenum. So when that space narrows, we shall call it pyloric stenosis. And with this, it will reduce on the amount of food which leaves the stomach to the duodenum. Then lastly, we can talk about the prevention. How do we prevent PUDs or peptic ulcer disease? The first way is taking NSAIDs with proton pump inhibitors or H2 antagonists or misoprostol, and with food. So remember, if we are talking about prevention, first go to the causes, then do the opposite of the causes. So the first one we have said NSAIDs. NSAIDs, it means non-steroidal anti-inflammatory drugs like diclofenac, aspirin, and others. We should take them with proton pump inhibitors. Then we can also say NSAIDs of COX-2 inhibitors. Remember we said NSAIDs, they block COX-1 and COX-2, but we have those which are selective, which only block the COX-2, and these ones have less side effects than the non-selective ones. So these may reduce the rate of ulcers compared to the non-selective ones. Then we should stop smoking. Then alcoholism also should be stopped. Remember we said people who smoke are likely to have increased hydrochloric acid production and less bicarbonate production. Avoid foods that irritate your stomach, that is controlling your diet, then having regular meals too. Lastly is learn how to control your stress levels. Remember we said stress causes peptic ulcer disease. Thanks for watching. Please don't forget to subscribe, share, and turn on notifications.